Beautiful. Excellent. So part of it is meant to be as organic of a conversation as it can be, as I sort of like lead you through questions. But part of it is scripted, so bear with me with that, okay? So thank you for agreeing to join me on this one-on-one. As you know, the aim of the interview is to hear more about your lived experiences as it relates to the domains of equity, diversity, and inclusivity. Your participation in this interview is voluntary. So if at any point you would like to step out, take a break, pause, end early, you're welcome to do so. Just let me know. These interviews, as you know, will be recorded in order for transcripts to be generated, but they will be anonymized. So if any names or identifiers are shared, they do get taken out after the fact. So don't feel bad if that comes out over the course of the interview. Do I have your consent to start?
You do.
Thank you. Before we get started, any questions for me?
No, I'm good. Thank you.
All right. And then for the records, could you please state your age, your gender, and your role at the Cancer Center?
I am 30, female, and a resident physician at the Dravinsky Cancer Center.
In which specialty?
In radiation oncology.
Thank you. So the very first question just asks you to define or explain a series of terms in sequential order, so we'll go through them one at a time. So how would you define or explain the term equity?
So I would define equity as, that's a good question. What is a good way to describe equity? So I would describe it as standardization, more or less, of the experiences of individuals, regardless of their characteristics, their personal characteristics that might cause them to be seen as different. For example, race, gender, or other qualifiers.
And when you say standardization, what do you mean?
Standardization or equalization would be another word that I would use.
So it's about the sameness of treatment?
Mm-hmm.
Okay. And then how would you define or explain diversity?
Diversity I would define as any group of individuals that have varying characteristics that can be seen. So, again, race, gender, preferences.
All right. And then lastly, how do you define or explain the term inclusivity or inclusion?
So I define inclusion as allowing these individuals in a particular group to participate in activities or experiences with no discrimination based on their characteristics.
Beautiful. So keeping those ideas or terms or themes in mind, do you see them having an influence on the patient-clinician relationship or, patient-clinician interactions? And if so, in what ways?
Sorry, is this question asking in my day-to-day life or just in general?
So I think let's focus first on the idea that, like, clinically speaking, do you think these domains of EDI play a role between, the patient and the clinician? And then, we can sort of broaden it out to more generally as well.
Mm-hmm. So I certainly think that they can play a role because, in any workplace, whether it's medical or not, we come with our own background experiences and our understanding of other people's experiences based on their backgrounds. And so, whether willingly or not willingly, we can sometimes tailor our conversations or interactions with our patients based on those experiences. And so, I think that certainly these things can seep into our interactions, whether we do so knowingly or not.
Can you think about more granularly examples of that?
Mm-hmm. So a common example that's come up is for my particular background. I know that in a family that might be very patriarchal or matriarchal, that let's say that their child comes in who may be of adult age, but the parent is speaking for them in the clinic. And as someone who's grown up and trained in Canada, that can make me very uncomfortable. But as someone of a South Indian background, it's something that I understand. And so I often find myself grappling with if I should be pushing more for the individual patient to be taking ownership of their care, or if I should allow this maternal or paternal figure to be the person to speak for the patient. And I don't know what the correct answer is. And I think I've kind of swung back and forth in my own practice with regards to that and what I've allowed.
So can you elaborate? Like, what is the reconciliation you have with yourself, or what are things that occur during those interactions, spoken or unspoken, as you try to navigate that dynamic?
So, the conversation that I have within myself is that I kind of reflect back on my own experiences and with my own parents and their involvement in my life when I was of that age. And I say, well, I know that they care for me and they love me. And so I'm kind of extrapolating from my own experience and say, well, they're doing this because they're afraid or they care. Mm-hmm. But at the same time, then I have to kind of take a step back and say, okay, but hold on, this is a person. I don't know if they feel the same way. Mm-hmm. And I think in the past, before I had a lot of time to think about this, maybe early as a medical student or as an undergrad student, I would say, oh, this is normal. And I would just allow the parent to continue to speak without maybe making a lot of effort to find out what the patient's perspectives might be outside of that relationship. But now, as I've gone further in my career and I've matured a little bit more and understand these different dynamics a little bit more, some of the things that I've done is I allow the parent to, of course, speak and express their concern, and we have those conversations. And then I turn to the patient. My first step is to turn to the patient and kind of address my questions directly to them. Mm-hmm. To encourage them and allow them to answer the questions. But if that still is not working, then at the end of the appointment, what I've done, and this hasn't happened very frequently, maybe on one or two occasions, what I've done is I've said, okay, well, it's been great to have the input from all members of the family, but as part of my job, I also need to do this individual assessment. So if it's okay, I'd like to speak to the so-and-so by themselves and just spend a few minutes. And to be honest, in my experience, nothing has necessarily changed, but I think what's important is to have that opportunity for the members of the family to participate, but also for the individual to kind of speak individually. Yeah. And that, I think, comes from sort of my cultural understanding of this dynamic again, because, I could just as easily say, no, that's not okay. And I want to speak to the patient individually. Mm-hmm. And medically speaking, that would be correct. But mm-hmm. culturally speaking, I recognize that wouldn't foster a very good relationship between right. me and the patient or me and their family.
Right. And so, trying to find that balance between therapeutic rapport, but also making sure that you are doing due diligence by mm-hmm. the person you're caring for legitimately.
Yeah. Yeah.
And so earlier you had mentioned more broadly when we were clarifying the scope of this question, what other things were you thinking of at the time?
Let me just think here. Other things. There's one experience that I always refer back to that's kind of stuck with me. And this was an experience that was interesting because it wasn't somebody that I had a personal therapeutic relationship with, but it's somebody that I had a personal relationship with, but they went through sort of the oncology experience. And essentially, to kind of summarize their experience, it's a family friend who we've known for a very long time, and his wife unfortunately was diagnosed with gastric cancer, and she went through a lot of treatments and clinical trials and everything, and she lived for 8 years or so, but unfortunately eventually she passed away from her disease. And and her husband never really had a chance to reconcile with everything that had happened. And so when I saw him a couple of years after she had passed, because he knows that I'm in the world of oncology, he kind of sat me down and ranted all of his feelings to me about what had happened. And what really shocked me was his perspective of her end of life care. And what he described was that near the end, her oncology team decided to stop offering her care. They didn't want to fight with her anymore. They wanted her to give up and focus on being comfortable. So they didn't want to offer her any more treatment, was his perspective of her end of life. And that, near the end, she was getting ill, going into respiratory distress. So she had multiple admissions. But his perspective was that on each admission, they didn't want to do anything for her. They just kept wanting to do palliative care. And he's like, they wanted her to die. And so, at one point in time, I guess they had consulted palliative care, and he described this as, and he's again an older gentleman of South Asian descent, and he described this as they sent an old white man to come and talk us into ending her life, is how he described the palliative care consult. And so he was very upset. He said, I would make a complaint to the college, but, I have no power here, so they wouldn't listen to me anyways. But what they did was wrong. And near the end, she was admitted again for respiratory distress. And she was on all sorts of comfort care medicine. And he's like, yeah, they gave her something and it killed her. And that's his idea of her end of life care.
Yeah.
And I was listening to this mortified, because that's the exact opposite of what we want our patients and their families to feel about their end of life care. And I don't know that his care team has any idea that they felt this way, because he communicated that to me, and I don't know that was communicated to them. So, with that in mind, I always think back to my own patients, especially the ones that are not talking, and how are they feeling about what's actually happening, what's their understanding and experience. And clearly it can be really different from what I think it is. So that's another experience that really sticks with me.
And I mean, there's a lot of very poignant themes that you brought out, even in that anecdote, because, there is that when you hear that, there's also a subtext there where you're like, oh, I see the decisions that the care team made. Like, I see where the transition towards pain and symptom management occurred, where there was a discussion about the lack of safety of proceeding with any further lines of treatment, but the way that it was received was truly the most negative or antagonistic side of that decision, but also very poignantly for this person to point out they sent an old white man to talk us into allowing her to die. Like, I hear a lot of points of disconnect of like, we weren't heard, there wasn't communication, and there was a disconnect, like from a perceived power dynamic between this individual who saw them and where they were in terms of their space. And so it felt very hierarchical. And so I do wonder whether a more culturally sensitive approach to that conversation may have changed that outlook.
And that's a question that was the first question that came to my mind was, it may very well be that they had these conversations, but also the other thing too that I really recognize is the importance of language and diction, because we put a lot of association to the words that we use, and there's a lot of connotations behind certain words that we use. But an individual who it doesn't speak English as their first language may not understand some of the connotations. So when we say we want to focus on comfort care, I don't know that he thinks that comfort care is the same thing that we think comfort care is. And so even the words that we use, it's, understanding that they may not mean the same thing to different people. So, yeah.
And so in that, I mean, that's a great example. Now, in your time as a trainee, have you ever been witness to a scenario where you watch someone else, have an interaction with a patient where they either really well incorporated the domains of EDI or opened those contexts and explored that, and it really helped and it was done very well, or conversely, a circumstance where it was done very poorly that stands out in your mind that you were witness to?
Mm-hmm. I'm sure I have. Let me think. Um, hmm, some good ones. I'm just thinking of, specific, like striking examples are not coming to mind right now, but I think that it's more telling that what I see in a day-to-day basis, probably a little bit more subtle, the examples that I see. And, I've definitely seen examples of people, interacting, keeping in mind these, principles. One example might be, oh, okay. You know what? Here's one that maybe wasn't the best experience, but we had an elderly lady who had come in to our skin clinic recently, and she had a large skin cancer on her thumb. And so we saw her for radiation consideration, but unfortunately it wasn't, it was too big for radiotherapy. And so we made a referral to a surgeon for amputation. And the attending that I was working with kind of just sort of went in and looked at it and said, oh yeah, no, that's got to go. I'm going to make a referral to a surgeon. You're going to lose the thumb. Yeah, I'm really sorry about that. And then sort of left. And then I kind of went back into the room with this, 91-year-old lady who currently lives independently. And I looked at her and she looked at me and she said, well, how am I going to eat without my thumb? And you realize how incredibly dependent her life, her independence, her quality of life are on this one thumb on her dominant hand. And for someone to just sort of come in and say, oh yeah, that's got to go, I'll make a referral to a surgeon, and walk out without giving this person the time to process, understand, feel heard, feel supported. Maybe it'll make a difference, maybe it won't, but I think that's one that kind of stuck with me, because this sort of small procedure will entirely change the course of this person's life. And so I think that warranted a little bit more conversation and support.
Well, like what I hear is, there wasn't that exploration that, albeit she is an older person, she is a functional, independent older person.
Mm-hmm.
And you are discussing a procedure that is going to take away that independence. And, what are her supports? What is her home environment like? Is there a capacity to be able to navigate additional like recovery periods if she needs it? Like, a lot of those things that color in magnitudes your day-to-day life that just like weren't explored, it sounds like.
Yeah.
And were you able to like, at least bridge some?
Yeah, so I was able to bridge some of that gap. It took a chunk of time, of course, but I was able to bridge some of those gaps and have some of those conversations, and also, let her know that depending on which direction you go with the surgeon, we can arrange some of these supports for you to help you stay independent as long as possible. Yeah. And, just give her a contact to link back to. Yeah. So that, that was all I was able to do for her. But I think, big. Yeah. But the conversation, I think, is the biggest thing, is realizing that it takes it's a huge emotional toll to process the loss of your independence. So that takes a little bit of time.
Yeah. So keeping that in mind, I mean, you've touched on a lot of really great examples around these themes. As you are in, the last part of your training, thinking back, have you ever received any formal training within these domains, or any sort of learning opportunities to exercise these skills within your program?
Formal training, I have not. The learning opportunities have been around depending on who you're working with in clinic. And there are people within our department who are very aware of some of these inequalities. And so it's, these have been conversations that we've had around individual patients, and it really depends on what you encounter. So a patient that I encounter might not be a patient that,
your headphones just cut out.
Damn it. It's a lot of money down the drain.
Oh no. I love how there's backups. So many options.
Normal people.
Yeah, I think you're just going to have to settle on the fact that there's not going to be a headphone option here.
Okay.
So you were saying about some of your staff and experiential learning, like how is it that your staff open that conversation? How do they, engage you in that discussion?
So the conversations, again, like I said, are very case dependent. So if, for example, we meet an individual and we see, let's say, again, as an example, when I was in gynae oncology clinic, I met a lady who was not very compliant with her follow-ups. And, your first thought might be, okay, well, this person is wasting my time, isn't showing up for appointments. That's not good. But this individual staff that I worked with had spent a lot of time with this patient in the past. And so she kind of, before we went to see the patient, we discussed her case and she went over with me, oh yeah, this individual, I spent a lot of time with her. She comes from a very difficult social background. These are her challenges. This is why she doesn't present for care. And so, she's made some alterations to how she approaches care for this individual so that she can come, whether it might be offering ride opportunities or trying to book multiple appointments together at the same time so that she doesn't have to make multiple visits and things like that so that she can receive the care that she needs. So I think it's, again, it's been case-based in that way. A lot of it has been with relation to access to care. We haven't really talked about, age sensitivity or racial sensitivity. Some of those other things I think haven't been discussed as much. But again, because there's no formalized curriculum and no formalized discussion, I don't know that that's ever really been thought about in that way.
And have you, in, either as a trainee or other times in your life, had informal opportunities that you've been able to seek out, whether those were seminars, discussions, whatever else may be that you've come across or sought out yourself?
So I know, on a couple of occasions, we've had, so on one occasion we did have an EDI talk that was available to us through McMaster University. But I don't remember the details of it, and it was at a time that I couldn't attend it, but I know that it was available. Mm-hmm. Another time that I've had this discussion was actually through a leadership seminar that I was doing, and this was one of the lectures on the leadership seminar. So that's another experience I had, or opportunity I had.
Were those mandatory things, or were those things you just sought out because you were interested?
I was interested, and it was entirely elective.
And where does that intrinsic motivation come from? Like, what drives you to want to seek it out?
So for me, personally, it's been the experiences that I've had as I've gone through my training and I've seen more patients. And I've recognized that I have a lot of limitations in my understanding of the scope of people's experiences and from different backgrounds. Mm-hmm. The cultural is one example. The other is gender, and in particular with relation to gender identity. Mm-hmm. It's something that's evolving, something that's new, and I haven't had any formal training or experience in the area. So I have a lot of concern about, if and when I have patients with varying gender identities that are coming to my care, what am I doing to make them feel included? What am I, am I being ignorant without realizing that I am, and things like that are definitely things that I think about, and so I have been looking out for opportunities where I can have that training and have that a little bit better understanding of how to be more inclusive. So that's been my personal sort of motivator.
Yeah. And when you think back, and I mean, yes, EDI is very much part of like the zeitgeist right now. It's very popular. It's very hip to talk about it. But when was the first time that you can recall that it came to the fore in your mind, that this was something that mattered and, you know, influenced people's lives? Maybe not under these labels. Maybe it wasn't like you actually labeling and being like, oh, this is an equity issue, or oh, this is a diversity issue. But when can you recollect sort of being faced with the reality that people came from different spaces and it mattered to talk about that?
Yeah, I was going to say I definitely did not have those titles. But I think that even, you know, when I was in, I could say that it could go back as far as high school or undergrad even, because I was involved in a lot of things, including debate and in all the United Nations, and sort of thinking about impacts that of the decisions that we make on people from different backgrounds in different countries around the world. I think that those were some exercises that started to get me thinking about the perspectives of other people. And I think, you know, one sort of defining moment that comes to mind is when I actually started working with the Red Cross in undergrad. So I was quite involved with the Red Cross, and one of my roles is I sat on the governance council for the province. And we, you know, focused on funding distribution throughout different programs around the province. And I lived in a province that had a strong First Nations and Métis population. And so we were talking about what are the best ways to distribute fundings to our First Nations communities such that they're worthwhile. But sort of we were sitting in a room of not a single First Nations or Métis person in this room making this decision, not understanding at all what we're trying to do. And I think that was one of those moments where I kind of just sat down and said, what are we doing? Like, where, you know, we could throw money at the problem or try to understand the problem and sort of address things in that way. And so I think those were some of the experiences that really started to make me think about, do I actually understand the experiences of other people when I'm talking about them or talking about their experiences?
And was that a enlightening opportunity, an uncomfortable one, an easy one? Like, what sorts of emotions did that evoke, having to face that recognition?
So it was a little bit of both. I think it was enlightening, and it was clearly something that's shaped who I am now and how I practice and how I approach my community now. And it was uncomfortable because my whole life I'd felt that I was a very well-informed and educated and compassionate person. And I kind of got to that point and I was like, I don't actually know anything about a lot of people. So I'm sitting here making my judgment calls and having my perspectives, but there are a lot of people that I have never met, I have never interacted with, I don't know anything about their experiences, and here I am making decisions about their lives. So I did not feel that I was in a position to be able to do that, and so that definitely made me feel uncomfortable.
Yeah, it's a sobering thought, right? Mm-hmm. Now, when you think back, you mentioned that there was never any formal training built into your curricula as a RADONC resident. Recognizing, and you've mentioned it yourself a number of times, when it is important to be trained and to be aware, what are ways in which you think this could be incorporated into training? Like, how would you have it done?
So I think that there are a couple of different things that need to happen at the same time for this to be sustainable and meaningful for both residents and the physicians and supervisors that they work with. And that is, I think that both residents need to have formal training, but also our supervisors need to have formal training, because it's almost that teaching to teach model, right? So if we're relying on our attendings and supervisors to teach us equity and diversity in a day-to-day clinical setting, but they don't actually know how to teach it or understand the framework, then even if they're well-intended, they won't be able to reflect all of the things. And one lecture in a half day is not what it takes to learn equity and diversity. So I think that it's certainly a place to start. Half days are a great way to introduce the topic, and doing case-based exercise and say, well, if this is a situation, what are your thoughts and feelings about this? How would you deal with this? So I think that those exercises are great half-day exercises to get residents to start thinking about equity, diversity, and inclusion. But I think that similar half days or training sessions are needed for our staff who have not thought about this very much throughout their practice. And so it allows them to start thinking about it in a critical way as well, in a structured way. And then hopefully when they have a resident working with them and they see a patient together, then both people are coming from the same place of knowledge, the same vocabulary and understanding of what these words and these discussions mean and how they should be structured. And I think that gives them the tool then to be able to address each patient's case on an individual basis. Because at the end of the day, I think we're going to learn through seeing cases. We're going to learn through seeing patients. But if we don't have the framework for how to discuss patient issues in a sensitive way, then it won't stick. And then, of course, there's also the issue of time, because it takes time to talk about these things. And so I don't know what a good solution is to the time issue, because we're always going to be strained in clinic. But I think that if we have the tools to talk about it and we're trained in it, then it becomes very quickly a 2-sentence during the case review portion of clinic, as opposed to a half-hour long discussion, because we're both fumbling around trying to find the right words to describe what we're experiencing.
You've mentioned time as being perhaps one prohibitive barrier. What other barriers do you perceive might be limiting to have staff or learners engage in these sorts of discussions?
So, I mean, yeah, as I said, time definitely. The other things that I think might be issues are, I think we can't ignore personal biases, right? So both staff and residents, we come with our own backgrounds, biases, and understandings of these issues, and so that can definitely be a barrier to how open an individual might be to taking in some of the information that may be given to them during these sessions. So that's another one. And another thing that I think might be an issue is that I've seen, and I've been guilty of this myself, at times I've kind of said, well, I treat everyone the same regardless of their background. So why do I need to sit down and do this stupid formalized training thing that's just, it's just a waste of a session. It's so floofy. And so that even that perspective itself is I think a big barrier to being receptive to these different sessions.
Sorry, the only reason I'm a little bit distracted, there was a spider. And so I'm like reconciling with the fact that there is a spider in the corner of my eye. And as an arachnophobe, that is hard. So the next question is, how comfortable do you feel when discussing these topics, when discussing these domains or integrating it into your practice? I know that you mentioned already some areas that you want to continue to get better at, namely around perhaps like transgender health issues, but also, like incorporating dialogue around people's gender identities and, including that space. But how, in other terms or in other domains, how comfortable do you feel?
I think that I feel falsely comfortable in these domains. Because I've spent so much time in the world of oncology and in dealing with sensitive issues of different people, I feel like I would be able to do that and be able to provide someone with a supportive space to discuss their concerns. But I think what I recognize also is that it's not just about being supportive and open when it comes to allowing a person to discuss some of their concerns around these issues. It's also about opening the door, giving them that the frameworks to help them sort of describe what it is that they're going through and what it is they're feeling. And so I don't think that I have enough training to be able to do that. So when I do that in my clinic, it's sort of a framework that I make up in my mind, and it's different with each patient, and it's not standardized. So I think that
and
that's
nor would you expect it to be, right?
Mm-hmm.
You wouldn't expect it to be standardized because people don't come in cookie cutter shapes.
No. But definitely, I think that's what I recognize as being a bit of a challenge.
And then sort of shifting more introspectively, more reflectively, has there been an instance where someone else has perhaps not taken the time to acknowledge your diverse identities or backgrounds or contexts, or not been equitable towards you, or not given you inclusive space, and that's affected you personally or professionally? Mm-hmm. Whether it was a colleague, a supervisor, a patient even.
Mm-hmm. I've been fortunate in the world of oncology, I think, because empathy is sort of a part of our trade. I can't say that I've experienced very much of that during oncology. I definitely have experienced a lot of it before oncology in medical school, and in other areas. For me particularly, I think I feel most of it around my gender. So a lot of conversations around what my life is supposed to look like as a result of my gender. So I think that that's, whether well-meaning or not, is definitely something that comes up.
Can you give examples?
Okay, so examples. One of the things I get asked quite a bit, actually, I guess we get now, when I'm discussing career planning with anyone, the first thing that they discuss with me is what my plans are for maternity leave. And it's funny to me because it's something that I don't care about. Maybe it will be something I care about at some point in my life, but it's certainly not the first discussion I want to have with a supervisor that I'm making career plans with. I don't care about maternity leave, but it's the first thing that always comes up. So I always find that a little funny. It's not, ill-meaning. It's never forceful or anything of that sort, but it definitely, changes the course of our discussion a little bit. So instead of having discussion about professional development, you're having more discussion about aspects of life that may not be important to you, but no one actually asked if it was important. So, those are more subtle things nowadays, but definitely as a medical student in some of the other areas of medicine where equity and diversity are not necessarily discussed as much, I've had discussions with supervisors where they have told me that I wasn't pretty enough for their specialty. So
seriously?
Yeah. Did I not tell you about this?
No.
Yeah. So
like derm? Was it like
No,
dermatology?
it was neuro.
Neurosurge.
Yeah.
Oh my gosh.
Mm-hmm.
How do you even begin to deconstruct that?
Yeah.
Wow. What did you even do in the moment?
I said, well, thank you for your advice. And then I went on with my life.
Wow. That is about as subtle as a ton of bricks.
Yeah. No, I believe the exact words were, when it doesn't matter how good you are at what you do, when you walk into the room, everyone needs to stop talking.
There's so much there. There's so much there. I'm sorry that you had to go through that. That's horrible. Good riddance that you are not having to live that existence today, right?
Medicine's evolved, but it hasn't evolved that much.
No, it certainly has not. Oh, good gosh. Okay. Mm-hmm. Last question then. Mm-hmm. Is there anything that you want said or discussed in that we haven't talked about so far as it relates to the overarching research question that is understanding how oncologists learn about and sort of understand EDI?
I don't have any particular questions, but I think in terms of comments, it's my sort of overarching comment here is that this is something that I have recognized throughout my training in oncology, and actually I have had discussions multiple times with my colleagues about the fact that this is something that I'm curious about, and we don't have a lot of formal discussions about our different experiences with regards to equity and diversity and inclusion, and how to address these issues when it comes to our patients. So I'm glad that this is something that will hopefully be coming down the pipeline for our trainees.
Yeah. All right. Any other comments that you want on the record?
Good. Thank you.
All right. Let me just pause recording then. Done. Hold on, did that actually stop? Because I can never know.